Jens Uevoet will provide an overview on how to assess deformation imaging and microarray function using two different techniques, tissue Doppler imaging and speckle tracking imaging. He will show us that we have to optimize the image for these two different modalities, and he will also show us how to provide some analysis of this data and also the limitation that we have to take into account.
In the following, I would like to show you how to quantify myocardial function. We have two methods to do so, tissue Doppler imaging and speckle tracking. And I would like to guide you through these two methods and show you some details of data acquisition for these methods. The most important thing, since we are talking about quantitative function, is that we have good images, good image loops, and we need several image loops to evaluate the function of the ventricle. Sometimes we have to put several image loops together, and therefore it's important that we have a good basis for timing. That means we have to have a good ECG. So it's very important that you apply the ECG electrodes very well in a way that they don't move during the examination and that they give a good signal, as you can see here on the screen. If this is done, you're ready for acquiring images. Let's start with tissue Doppler imaging. For this, we actually need good quality image data. So image quality is the most important thing. Otherwise, it's nothing special what you have to do. Since tissue Doppler is a technique that is one-dimensional, we usually acquire apical images. And when we do so, we are able to measure longitudinal function of the myocardium in all segments of the left ventricle. Therefore, we are looking for a good apical view for the 4-chamber view, the 3-chamber view, and the 2-chamber view. Tissue Doppler is a technique which offers a very high temporal resolution. To take advantage of that, we have to optimize the images. For that, we reduce the sector size, we reduce the depth, and we can also play with the frame rate button on the machine. I try to show you that here on this example. When you watch the screen, you will see the frames per second shown here in the image. Watch this number and see what happens when I change the different settings. If I reduce the sector size, you will see how the frames per second go up. If I increase the sector size, it goes down. Similar things happen when I change the depth. Then also there, the frame rate goes up. Third, I have a frame rate button on the machine. Also there, I can optimize the frame rate. What should we try to achieve? We should try to achieve an image where we can see the entire ventricle. So we should cover the entire ventricle, don't cut the myocardium, especially in the apex, and we reduce the depth so far that we still see the mitral valve clearly in the image. If we have that, we switch to tissue Doppler, and you see the colors of the tissue Doppler appearing on the screen. Make the tissue Doppler color box as big as the sector, so the color covers the entire image area. And if you have this image, you ask the patient to hold breath, and then you can acquire your images. Can you please stop breathing? Breathe out and stop. I'm usually acquiring 3 cardiac beats, not only 1. Tissue Doppler can sometimes be a bit noisy, so it's good to have 2 or 3 beats to compare. I increase therefore the acquisition to 3 beats and store this image. That's basically it. And now you move to the 3- and 2-chamber view and repeat the same procedure. Take care that you have a good image quality. Ask the patient to stop breathing. Please stop breathing now. Switch the tissue Doppler on. and acquire once you've seen that 3 beats have passed in good quality. Finally, the 2-chamber view. Stop breathing, please. And we're done. So that's quite easy. The interesting part in tissue Doppler imaging comes now with the post-processing of the data. For that, we need something in addition. We need timing information. And timing information comes from the valves. So we want to know when do the aortic and the mitral valve open and close. Therefore, I have to acquire 2 more images. One is Doppler through the mitral valve. It doesn't need to be particularly nice or good quality. The only thing what I need here is the closing and opening artifact of the valve. The second acquisition for timing is the aortic valve. That's even more important. Also here, it's important to have the opening and closing artifacts. Sometimes it can happen that the patient has an irregular heartbeat, as you can see here. This is something you should avoid. So this is not a good image loop that has to be repeated. It is also important that the heart rate does not differ too much between the acquisitions, otherwise you will get weird results. So after having taken these images, we can analyze. The first thing what we have to do is we have to measure the opening and closure of the valves. For that we have a special menu which can measure the event timing, can be used for measuring the event timing. And here we have the aortic valve signal, and we will now indicate to the machine where the aortic valve is opening and closing. The machine will remember these values or these measurements relative to the QRS complex. And you see on the screen the little yellow dots indicating where the QRS complex is recognized by the machine, and we measure according to this recognized peak. We do the same thing for the mitral valve. Mitral valve opening and closure is indicated here, and then we have the timing. And now we are ready for analyzing tissue Doppler data. Depending on the machine, you will find different programs. And here you see one of these programs. And what you can see here is the loop we have acquired a few minutes ago. And you see already the timing implanted into the display for the curves. So we know already when the aortic valve is opening and closing and when the mitral valve is opening and closing. And we have a lot of tissue Doppler data now from all the image, and we can go with our mouse through the image and we can see how the tissue Doppler signal is changing. What we see here on this screen is the velocity. So this is how fast the myocardium is moving towards the transducer and away from the transducer. You see this as positive and negative peaks. You will notice when you go through the myocardium that you will measure high values at the base, and the further you go towards the apex, you will measure lower values until you reach the apex and you have a very, very small signal. We can do more things with tissue Doppler. We can not only measure the velocity, we can also post-process the data in a way that we get other parameters. For example, the motion of the myocardium. And for that, we can just tell the computer to calculate the integral of the velocity. And when we go now through the same wall, we see another curve, and this is the motion curve. This motion curve shows us how the myocardium is moving up and down. And this is pretty much the same what you would get when you would measure an M mode through the valve ring. And if I go up through the wall, you see that also the motion is becoming less and less. This is the normal behavior in a normal heart. But we can do more. We can also calculate the deformation of the myocardium, and for this we have the parameters strain and strain rate. Strain rate shows us the velocity of shortening. And we can also go through the myocardium here and look at the different regions of the myocardium, but we will notice that we don't see a gradient here. So strain rates are more or less the same everywhere in the myocardium. If we compare, for example, here, this basal region and this apical region, you see that the amplitude during systole is similar. The strain rate curves look a bit similar to the velocity curves, but inverted. So we have negative peaks during systole, and this is because the myocardium in longitudinal direction is shortening during systole. And we have positive peaks during diastole, and this is because the myocardium is lengthening during the early filling and after atrial contraction. The last parameter we can calculate from our tissue Doppler data is strain. Strain is the integral of strain rate, and it shows us the deformation of the myocardium. And as you can see here, I just have to press a button and we get the strain curves instead of the strain rate curves. Also here, you see that the strain curves have no relevant gradient between the apex and the base. They look pretty much the same. What do we see here? We see a downward motion or a downslope of this curve, indicating that there is shortening of the myocardium. And after aortic valve closure, we see an upward motion or an upward slope of this curve, indicating that the myocardium is lengthening. After aortic valve, after atrial contraction, we have a second upslope of this curve, indicating again myocardial lengthening. So these are normal curves, and I thought it might be interesting to show you how this can be used also in pathology. Therefore, I brought you a stress echo case, and there I usually take tissue Doppler data during the stress echo examination. And if you're not sure what you should think about the result of this stress echo, you can use the underlying tissue Doppler data and analyze the strain curves and see what's going on with the patient. So I'm going to switch now to this other patient. You see here the typical stress echo layout. We have different stages from baseline to peak dose. This is a dobutamine stress echo, and we have the different acquisitions, parasternal long axis, short axis, and the three apical views. You do not see a lot of the color Doppler, of the tissue Doppler in the background. You only see these little color bars that indicate that we have not only grayscale data, but also tissue Doppler data acquired. Let's have a look at the baseline and at the peak dose 4-chamber view. You see this is everyday live quality, so this is not a perfect case. And you might wonder if there is anything going on in this heart or not. Is there ischemia during the stress or not? How can we find out? We go to our peak acquisition and we switch to the analysis tool, and we can immediately analyze the tissue Doppler data. And if we calculate the strain, we will see that there is a normal looking strain curve, for example here. There's a normal looking strain curve here. You see also that these data might be a bit noisy, but the shape is always the same. We have a shortening during systole. But if we go into this region, we suddenly see a completely different pattern. We see that there is no shortening during systole, but that there is something newly occurring. There is a shortening which happens much, much later than in the normal region. This is post-systolic shortening. And if you find something like that during a stress echo examination, you can be pretty sure that this is a stress-induced ischemia if it occurs newly during the examination. The second way of looking at myocardial function is speckle tracking. Speckle tracking works completely different. We are not using the Doppler principle, but we use image analysis. That also tells us that we have to have very good image quality because we want to analyze details of the images. Therefore, the important thing of our image acquisition is that the images are simply perfect. Again, we need a good ECG. We need a sector that covers all the left ventricle. But this time we do not optimize so intensively for frame rate, because we do not only want frame rate, we also want a good lateral resolution of the images. Therefore, we have to find a trade-off between a high frame rate and a good lateral resolution of the images. And when we have found that, then we just acquire 3 apical views if we want to analyze these apical views. So, what we have to acquire is a 4-chamber view, a 3-chamber view, and a 2-chamber view. As you can see here, this is a good quality image. We don't need to improve anything there. A 2-chamber view, which is also of good quality, and a 3-chamber view. You should take care that you don't have reverberation artifacts in the image. They often appear at the very apex and are stationary, bright artifacts. If you have those, you have to move your probe position a little bit to get rid of them. Once you've acquired these images, you can start analyzing already. We usually start with the apical long axis view. Why is that? The apical long axis view helps us to do timing. We see both valves in this view, so we know when the aortic valve is opening and closing, and we also know when the mitral valve is opening and closing. For analysis, we just need to indicate a few points around the endocardium, and then the computer will suggest a certain endocardial contour. You can agree to that or not, so you can modify it a little bit if you think that this contour is not good. And once you find it's good, then you process. And this is already the result of the processing. That goes fast. The computer indicates that it thinks that all the segments of this 3-chamber view have good tracking quality. But don't believe the computers. Look yourself. This is very important. And it's the only moment in the entire chain of processing when you can do so. So go very carefully through the image, look at these little dots, these little color dots here, and see how they follow the myocardium. And if you're satisfied with that, then you can accept the image or the processing. The next step is to indicate when aortic valve is closing. Also here the computer helps you. It suggests a certain point in time, which is based on the strain measurements already. But you can overrule that if you want. So you can scroll back and forth in the loop, and you can watch the aortic valve. When you think it's closing, then you indicate that. And you will see that this is usually very close to the suggestion of the computer. And there's the first tracking result. This is a normal heart of a rather sporty person, so the basic heart rate is low, and this heart is also not doing too much at that moment. So the global strain, which we measure here, which is the shortening, the systolic shortening of this entire contour during systole, is 18%, which is low normal. So as a second loop, we analyze the 4-chamber view. And the procedure is exactly the same. We indicate the basal septum, the basal lateral wall, and the apical region. We correct the contour if we find we need to do so. Maybe we can go a little bit outside here in the lateral wall, for example. We can adjust the width of the region of interest, and then we process the data. Also here, it's very important to check the tracking result visually and see if these little color dots really follow the motion of the myocardium. And only if you're happy with that, approve it. Now we have done already the 4-chamber view and the 3-chamber view. And the last thing we have to do is an analysis of the 2-chamber view, which goes exactly the same way. And now you see that the computer is suggesting that the tracking result in the apical segments is not good, as you can see here with these red crosses. And indeed, when you look at the little dots, they do not properly follow the myocardium. So you have a chance to recalculate that by adjusting the region of interest slightly. And then we can reprocess and hopefully get a better tracking result. Now I'm satisfied with the tracking result and I approve it. And once we've done that, we see all the tracking results together in one view. And the nice thing is that we have something which is called a bullseye view. And this bullseye view summarizes the tracking results from all the 3 apical views into one image. And you get a very nice overview of the regional myocardial function. By just looking at the colors and the end systolic values, you can estimate that this is a normal heart. You can also look at the global strain values, and when you look at the global strain values, which are minus 18.6 in this case, you also see that this heart has a normal global function. So this is a patient who suffered an anterior infarct, and let's try what happens when we do the same analysis in this patient. We start again with the 3-chamber view. We indicate where the heart is. We get an initial suggestion of the myocardial contour, which we actually do not need to modify too much in this example. And we see a good tracking result, which we can approve as it is. We look for the aortic valve closure, and we find that the computer makes a perfect suggestion, so we can accept it as it is. You see already in this image that the global strain, which is indicated here, is much lower than in the previous example. We have a global strain of minus 12, which is clearly pathologic. As a second view, we have to analyze the 4-chamber view, and also here I'm happy with the tracking result and accept. The last view to be analyzed is the 2-chamber view, and just a little adjustment, and the processing is done. And now you see that this summary looks completely different to the previous example. We have a bit of red color in our bullseye view, but we have also here, especially in the apex, only rosé or even a little bit of blue. And that tells us that the function in this region is much lower. Also, when we look at the curves, we can see clearly that we have 2 different types of curves. We have strain curves, which peak at the end of systole at the aortic valve closure, which is indicated by the green line. But we also have several curves which show a clear post-systolic shortening. So we have less shortening during systole, but we have marked post-systolic shortening after aortic valve closure. And when you look at this, you will find that this happens exactly in the infarct area. And we have also a special map for that. We can not only show the end systolic value, but we can also show the post-systolic shortening in our color map, and then we can see clearly where post-systolic shortening happens. So you have noticed that some of these curves show post-systolic shortening. and postsystolic shortening appears exactly in the area of the infarct. And we have a special color map for that, which can indicate where postsystolic shortening is. For this, I just have to change the color map from the end-systolic strain color map to the postsystolic shortening color map, and you see how impressively clear you can show the region of the infarct by using postsystolic shortening as an indicator. So if you quantify regional myocardial function, then you should know that postsystolic shortening is a very good indicator of regional dysfunction, but it's not specific for something. It could be either a scar or ischemia. It depends on the context. So I hope I could show you how you can use tissue Doppler and speckle tracking for quantifying regional and global myocardial function.
So the key messages of this examination is that first we have to optimize the images, quality, to optimize the settings for the different modalities, but also to record several loops, and finally to take into account that we have to look at the valve in order to have a good timing for an appropriate analysis of the data.